introduce James, Daniel, George, Raul, and Gabriel, and who's driving this project. And those who are not familiar with the research project that we have in the hub, North Coast Hub and Health Promotion, have been supporting a research community research program since 2012, I think. It's almost 9 years now. So we've been working mostly the fourth year medical students from Western Sydney Uni and some Wollongong Uni. So we've been working collaboratively with the University Centre for Rural Health. And so this is last year's project on sexualized drug use. And I'm based in Lismore. I manage the harm reduction and health promotion with the North Coast Hub, and I work closely with within public health. And I just wanted to straight away acknowledge Dr. Natalie Edmiston for being the primary supervisor for this batch. And so I just wanted to give the introduction to that, but also I just want to quickly acknowledge the past, present, and emerging traditional custodians of a number of Aboriginal and Torres Strait Islander nations on which we live and work, including any Aboriginal colleagues who are attending this meeting today. And Sashi, thanks again for your secretarial support. So without anything else, I just wanted to hand this over to George, Daniel, and all the teams. And congratulations for salvaging this program that was, I think one of you, Daniel, or someone may have mentioned that how it was almost dropped through the cracks. But thanks everyone for salvaging. It's a great topic that we will be keen to support. Off to you.
Okay. So hello, hi everyone. My name is Rahul. This is George, and we've got Gabriel with us as well. The last two students, James and Daniel, they just had a tutorial on, so they'll just be logging on shortly. And before we get started, we just wanted to thank the support of the University Centre for Rural Health and PASH for all their support, as well as our supervisor, Natalie Edmiston, and supervisor Franklin for all their support along the way as well. So our project is about evaluating the accessibility and relevance of online health promotion resources regarding sexualized drug use. So just a bit of background about it. So sexualized drug use involves the use of drugs either before or during sexual practices. And chemsex is a specific subset of sexualized drug use, and that involves the use of methamphetamine, mephedrone, or GHB. So what we know about SDU, so SDU is a phenomenon that is most commonly associated and documented in men who have sex with men populations, so MSM populations. And despite the overwhelming literature published in these urban MSM populations, preliminary studies have identified that sexualized drug use actually occurs across all sexual orientations in both men and women. So this emphasizes a gap in the current literature with regards to sexualized drug use in non-MSM populations, as well as the specific need for health promotion resources to focus on the broader populations, not just MSM populations. So health promotion is the process of enabling people to increase control over and to improve their health. Therefore, there is a need for good and accessible health promotion to combat the health issues that are associated with sexualized drug use. Additionally, resources must be tailored to their population of interest. So that could be young people, as we've said, men who have sex with men, women who have sex with women, etc., such that they target the specific community needs. And lastly, to the best of our knowledge, no prior study exists that both synthesizes existing literature on sexualized drug use and also evaluates the available health promotion resources.
So the principal aims of our studies were we were going to identify sexual health and psychosocial outcomes of STU that are presently reported in the literature. And then using these outcomes we found, we hope to use that as a benchmark to assess the ability of existing health promotion resources in addressing these issues.
So like George said, there were two parts of the study, the literature review and the health promotion resources search strategy. So for the literature review, we searched a few online databases, PubMed, Embase, Cochrane, Medline, and we used some of the search terms below. Just to note, the terms Australia and heterosexual, they weren't used in all searches. It was just to help us find some Australia specific knowledge, but it didn't actually limit the scope of what we searched for. And we found, as you can see through the diagram, after all the searches, we narrowed it down to 17 studies that were included in the qualitative analysis. And the full text selection involved a critical appraisal with Joanna Briggs criteria. And that was done between the 5 of us, with 3 looking for the studies initially, and then 2 independent, picking which ones would be included.
Can you hear me?
Yeah.
So our health promotion resource search strategy basically involved initially contacting local sexual health organizations, one of which was ACON. They gave us a bunch of resources to look into specific health promotion resources for sexualized drug use. We then went from there and conducted a bunch of online searches, because the logic behind a lot of health promotion resources in the current age is that they should be accessible via online websites, which is Glynn et al. Shows that that's the preferred method. So as such, by using the resources ACON gave us, and also conducting some online searches with our primary search terms and secondary search terms below to simulate what an individual looking for help regarding these topics would do, we came up with our resource strategy.
So moving on to the results part. So in terms of the results of the literature review we did on sexualized drug use, we found that there were 3 main categories of sexualized drug use outcomes that we discovered through the search. So they were sexual health risk factors, psychosocial outcomes, and sexual health outcomes. And we'll be going through these in a little bit more detail.
So in terms of our sexual health risk factors, we found a number of associations in the literature. So we found that SDU increased the risk of condomless anal intercourse, group sex, multiple partners, and injecting drug use. And those are all found throughout multiple studies. However, we also found that SDU improved several sexual health risk factors. It was associated with increased use of PrEP and increased STI screening rates.
We also found, regarding sexual health outcomes, that sexualized drug use was associated with increased risk of having hepatitis C, with STIs and HIV. In particular with HIV, one of the studies reported that HIV was common, up to 4 times more common.
So in terms of the psychosocial outcomes, all 6 of our studies found that SDU was associated with poorer mental health outcomes, and 3 studies specifically found it to be associated with higher rates of diagnosed depression or anxiety. There are ongoing issues with SDU related to consent. So some studies have highlighted that SDU participants experience non-consensual sexual contact in 15% of cases, which is much higher than in the average population, which is about 3%. And in terms of peer pressure, this was again something else that was noted as significantly higher in SDU, up to about 19% in terms of taking drugs and or participating in unwanted sexual encounters.
So in terms of the results for the health promotion evaluation, we decided to use the Ottawa Charter as a benchmark for the health promotion resources, as it is the WHO gold standard. So the 5 key action areas of the Ottawa Charter include strengthening community action, developing personal skills, creating supportive environments, reorienting health services, and building healthy public policy. And for the purpose of this presentation, rather than discussing all 15 of our included health promotion resources, we will be discussing the exemplar ones that addressed at least 4 out of 5 of these key action areas. Additionally, we also used the 3 domains of the health issues identified from our literature review that we just went through. And those were sexual health risk factors, sexual health outcomes, and psychosocial outcomes.
So I'm going to just talk through some of our exemplar resources. So we had a resource which was the only resource which identified all 5 of the Ottawa Charter principles, and that was how hard. The things I'm going to point out throughout as I go through some of these resources is which population they target, obviously the involved criteria from the Ottawa Charter, the harm categories they address, and were they accessible via Google search? So could someone who wants to find information find them easily? So the target that was specific for how hard was MSM. So some of our research, which we'll talk about later, has found that there is there's other populations that actually take part in sexualized drug use, so that's important. It did involve all 5 criteria. The harms addressed were sexual health risk factors and outcomes. So it missed out on the psychosocial element, which is quite significant and is a trend that we'll see as we go through. And it did not appear on a systematic Google search. The next resource, which is let's talk about it, Chemsex support. The thing that was special about this resource was that it targeted a whole bunch of populations. So it didn't just focus on MSM, which was obviously more prevalent, but it focused on MSM, heterosexual relationships, also young people as well. There was a bit of a focus. And it had a rating of 4 out of 5 for the Ottawa Charter principles that it targeted. And the harm categories, once again, missed out on the psychosocial elements, and this one did appear on a systematic Google search. Then we have StimCheck, which once again just focused on MSM. It had a rating of 4 out of 5 as well, and it missed out on the psychosocial element, and it did not appear on a simple Google search. And we have Down and Dirty, which focused on MSM once more, a rating of 4 out of 5, and it missed out on the psychosocial, which you can see is a bit of a trend here, and it did not appear on a systematic Google search.
So yeah, in summary, I guess what we found with our literature review was that there were a lot of increased sexual health risk factors and poorer sexual health outcomes associated with STU. And we postulate this could possibly be due to increased traumatic sexual practices, which you see in STU, increasing the risk of STI transmission. We also saw that there were those increased positive impacts of STU on PrEP adherence and STI screening. And we think that those are potential avenues for education or intervention regarding sexualized drug use.
So sexualized drug use was associated with poor psychosocial outcomes. We found that the link between the psychosocial issues and it being a consequence of SDU is kind of unreported. So there's quite a significant underrepresentation of this in health promotion material.
And in terms of the health promotion resources, so we found that there was a definite lack of ability to find these resources by simple Google search, which is obviously problematic for engagers in sexualized drug use. There was a big gap in women who have sex with women populations and heterosexual populations that these health promotion resources were targeting. There was often a restrictive focus on chemsex rather than sexualized drug use. So just focusing on the 3 drugs that we mentioned earlier. Only one of these resources specifically targeted young people. All 15 of them did address sexual health outcomes, which was good, but only 6 of them addressed psychosocial health outcomes.
And in terms of evaluating them with regards to the Ottawa Health Charter, so as we mentioned, the baseline we had was that they had to address at least 2 out of 5 principles. The most common principle that was that these resources were successful in achieving, 14 of them achieved creating supportive environments. So as outlined by WHO, that involves connecting people with inclusive services, using vernacular that's appropriate to their community, etc. And the least achieved criteria was strengthening community action. So only 3 resources did this, and that involves encouraging self-efficacy, social support, and increasing public contribution. So based on these, our recommendations are that health promotion resources should serve to target novel populations. So the literature has extensively identified that SDU does occur in heterosexual couples, it does occur in WSW couples, and there is a significant underrepresentation of those in health promotion. There's also a need to target at-risk groups. So only one study was targeting the young people, and that's something else that should be addressed. Another thing should be a greater focus on psychosocial outcomes, particularly of those ones that were higher up on the Ottawa Charter, and also achieving a holistic criteria of the Ottawa Charter.
So our limitations, so the first one that we've stated is that we're unable to assess targeted ads. So what this means is a lot of health promotion resources, rather than strictly just appearing on a Google search, they also use social media platforms such as Facebook or Instagram, using targeted ads to target the population through whatever complex algorithms these social media websites have. So obviously we couldn't access those ourselves, and it would have been hard to systematically do so. All included studies were cross-sectional. It was also difficult to identify a true SDU population. And the variations in SDU patterns across countries and rural urban divide, there was changes that we couldn't directly assess. That's just basically due to the whatever available resources we had. And once again, as was mentioned probably previously, we were hoping to further investigate that ourselves with our initial program that we wanted to do, which was going to be a survey undertaken at a major music festival in the Northern Rivers area, but unfortunately due to COVID, we weren't able to do that. And then also there were varying definitions in terminology. So the way people describe chemsex versus sexualized drug use, what they counted as chemsex. And so that made it a bit harder to compare things. And our recommendations was that there's a consensus-driven unification of terminology in the field. There's more research into different SDU populations, and that there's that we improve health promotion access and delivery. Thank you very much. That is the end of our presentation. We're happy to field questions. I think we have one in the chat maybe. How did you find these resources? Interested in terms of how priority population groups are otherwise targeted? Yeah, so I'll read out the question.
How do we
so,
go back?
Really interesting about the resources not being accessible through systematic Google search. How did you find these resources? Interested in terms of how priority populations are otherwise targeted. So initially, some of our resources we got through ACON. They gave us some websites which we were able to sort of snowball and find other resources through that, which was the initial sort of where we found resources. And then we also conducted a systemic Google search using these primary search terms. So sexualized drug use, SDU, chemsex, sex and drugs, party and play, and slam sex. And there were terms that we'd identified in literature that were used interchangeably. And then we combined those with secondary search terms, so health resource, health promotion, which are things we sort of thought that individuals who were seeking help or who were seeking access to these health promotion resources would combine those terms together. And that was how we made that systematic search strategy. And then interested in terms of how priority populations groups are otherwise like, yeah, so like we said, unfortunately, just because of the way we wanted to make this more a bit systematic, we weren't able to include things like targeted social media apps. So like I said before, things like Facebook, Instagram, Grindr as well, things like that, which we weren't able to properly incorporate into that. I hope that answers the question.
So I'll answer the question regarding HIV. I'll just go back to the slide. So we found, I think there was a bi-directional relationship with some studies saying that if you were HIV positive, you're more likely to be using those sexualized, be engaged with sexualized drug use, but also the other way around, if you were sexualized drug user, you were more likely to be HIV positive. Does that answer the question that you had?
And then, well, all the resources from Australia, no, they weren't all just from Australia. It was more initially when we were starting, we were hoping to just use Australian resources, and then we realized that this is a very new field, so we had to broaden our scope. Were these POZ people undetected?
So I'm not sure what that question.
Oh, positive.
Positive heterosexual, HIV heterosexual.
I'm not sure off the top of my head. Does anyone?
I don't think a lot of these studies weren't focused on HIV as the focus of it. I think, yeah, we didn't address that specifically.
It was more of like one of the outcomes of their test, but it wasn't a primary focus.
Yeah, yeah.
Any other questions? Any comments from Natalie or any other support? And also Jen was initially talking about the topic many months ago. There's anyone has any more questions, because it's unusual that we finish that early.
It's Natalie here. Yeah, so thank you, students, for the presentation. That was really well done. So, I guess the main question that comes up for me is what's the best resource we should be directing people to if they're, if we're concerned about their chemsex use, or their that they might be at risk of harms related to chemsex. What resource would you suggest that we direct people to?
So I suppose the first thing we should mention there is it would be dependent on what population the patient identifies with, if any at all. So one of the, so if we go back one slide. Back one slide. So so this one, how hard, is very, very good for MSM populations. It's exhaustive. It is does a really good job at creating a supportive environment. It uses community vernacular and things like that. So if that patient was part of the MSM community, I think that'd be a great resource. If they were part of any other community, so if they were young people, if they were heterosexual, then I would say let's talk about it. Chemsex support. Maybe not as good from the perspective of using all the Ottawa Charter criteria, but it is a bit more accessible to the general population and less specific. And it does a really good job at reorientating pre-existing health services. So it gives you links to hotlines, services that's specific for sex and drugs. And it is generally very informative, and it's also very accessible. So if you told them, here, this is a resource, they wouldn't have to go through some complex route. They'd just be able to easily appear on a Google search if they just looked up, let's talk about a chemsex support. But yeah, it's sort of right now, I would say that, what we're missing would be a good resource which sort of incorporates everything together. But I imagine that's very hard because, you want to make it welcoming to everyone, but then also you want to make it specific to each different population. So we're in a bit of a niche where you have a whole bunch of different communities who identify in very different ways, who are all accessing a similar sort of resource. But yeah, right now those would be the two we recommend probably best. And it just depends on the population that you would like to refer to.
And just to reiterate, yeah, like how hard it is a good chemsex resource, but it's like extremely difficult to find. Like even if you searched up using our primary and secondary terms, you wouldn't find it. And even if you searched up how hard, you wouldn't find it. And if you search up how hard and chemsex, it's pretty hard to find. So yeah, that's a significant limitation with that one. But if you can find it, is, as Dan said, very exhaustive.
So can you share like their website address for that one then, in case people are wanting to find it?
And also this great work, guys. Congratulations. Yeah, really nicely done. it makes me think that we need a resource from your findings. So, yeah, something that's accessible, easy, easy, especially for youth, youth and young adults. It's probably really important, and given the amount of festival information we've already obtained from previous research components, it makes you think, oh, okay, we really need, not like the ACON hard resource, but we really need something like this Chemsex support resource that we can have available for anyone that's not target driven, that talks about, the aspects of chemsex, sexualized drug use. Yeah.
To answer Naomi's question, we didn't, because of COVID, we weren't able to actually get on the ground and engage with the community or get any data that was reflective in that way. So everything we did was entirely online, literature-based search.
Sure.
It was all
and all the literature was based on inner city. Most of the literature was based on inner city things. So
which even gives it even more reason why we need to look at, because all the festivals, music festivals where sexualized drug use happens, a lot of the time, chemsex happens, or nightclubs. Well, nightclubs have been shut down, and COVID shut down, as we know, the festivals, but it makes it even more of an argument that we need to get a generic resource out there statewide that speaks to everyone around, SDU.
And I think, if anyone was looking to do research into this now that COVID's going down a bit, just in terms of this true SDU population, I think one thing we've identified is there's a real underrepresentation of research in rural areas. Most of the studies now are set in sexual health clinics. So, if there's a way for people to, get out in the community as opposed to at sexual health clinics, and then also trying not to do MSM research, because there's a fair bit of that, but there's nothing else really beyond that.
It's quite discriminatory, really, because it's alluding to the fact that the only people that do SDU are MSMs, predominantly. And I know that's always been a leading edge because of HIV driven it that way. But it's certainly becoming more and more across all communities.
Yeah, there are some really good papers that are specifically only did WSW research, and they're really quite interesting to read. But yeah, they're few and far between.
Right.
I'd have thought sexualised drug use has been around forever with alcohol, if we include alcohol in that.
Yeah.
Yeah, so on that note, a lot of the studies didn't include, excluded alcohol as being considered part of sexualized drug use, and certainly in the definition of chemsex, it wasn't included.
Yeah.
There were a few studies that did include it, which I guess would skew some of the data we had. But yeah, it's a
22.
very widely spread thing that's happening.
So I've got a couple of questions here. Just wondering how much the target population is likely to engage with another resource regardless of how targeted, and if the resource may be better directed in improving the skills of people engaged with targeted populations in meaningful conversations. Yeah, so that is obviously, and that's one of the principles of the Ottawa Charter is, improving the skills of people engaging with target populations. Yeah, so that's one of the skills of the Ottawa Charter that, one of the criteria that that health promotion resources should engage with. That's definitely true. I think, mainly that the problem about getting the target population to engage, that's a pretty fair comment. I think the thing is that because that target population is now quite broad, it'd be hard to be able to specifically target that target population. But I think maybe a resource that is a bit more general and has the option to offshoot to specific resources could be good, or one with easy referral options for people who want those specific populations targeted. But I imagine it will be quite a mission to get something that's good, meaningful, not too long, and is available to a bunch of people. I can definitely see that as a problem. Can you post this WSW resource? We did. Okay.
Yep.
Who's a sexual health clinician? I would like to say that often occurs completely unrelated to outcomes. Yeah, only needs to jump 1 class. Okay. Yeah, that's definitely true. I think obviously something that we came across in the show was that was the case. I think the only reason we were mentioning things like festivals and stuff, it was a really good access for us to go and interact with like a young population. So that would be a different population than what is usually explored in the Chemsex sphere, and thus sort of see how much it's occurring in those populations. I think that's the only reason we were bringing that up. But yeah, definitely does occur outside of those things for sure. Yeah. So obviously, in an ideal world, we would have liked to have explored these other platforms as well for their things like targeting, health promotion, and stuff like that. But yeah.
It is 1 o'clock, although we have another half an hour in Zoom, but I know that you're all busy.
Quickly, there's one question there that's just come through before we wrap up from Edda. Were trans and gender diverse populations mentioned anywhere in the literature reviewed?
They weren't mentioned in our literature review. At the most we had was like some studies mentioned gay and bisexual men, but there were none that mentioned gender diverse. So yeah, that's something that again is something that probably should be investigated a bit better.
I just want to quickly mention that when we started this exploring this topic, and you guys actually prepared, ready to go to do a full survey at a festival, and then COVID hits, and then we had to completely change everything. So we're very thankful that you kept the topic and also focused on the literature review, although the scope of the community study in your busy 4th year student work, we don't normally expect people to go full details for a full study, but this is certainly an amazing sets of information for us to scratch and look forward to the future, because from the health promotion or programmatic planning point of view, we have a lot more to explore. And so a big thank you for you, and also Natalie, really appreciate you keeping it together and giving us enough motivation to keep going. So thank you again.
Yeah, thanks everyone for tuning in.
Thank you very much.
Thank you.